build care for thousands and hundreds of thousands of people in a really impressive way. He's the CEO of Liza Health, which is building an AI-enabled platform for primary care, and before that, he co-founded and led Iora Health, one of the country's most influential models for relationship-centered primary care. And before that, he used Renaissance before we did, and built some great practices 20, 25 years, 30 years ago already, with people who were friends of both of ours, really good people in the union. Rashika's going to walk us through the afternoon program and help us frame the conversations in the very exciting afternoon to come. Rashika.
So it's wonderful to be here. It's wonderful to be here and see so many old friends. As Michael said, I'm a primary care doctor. My journey doing this started a little over, almost 25 years ago. And I've told this story often, but I remember I was a primary care doc in a, maybe I'll mention, MGH affiliated practice. It was a dark day in February. It was cold and dark, and I had 20-something, maybe 30 patients booked. They all decided to show up. They had just put this new EHR in, and I barely had time to sort of, I wasn't really good at doing my points and clicks to get my RVUs. And so what I'd do is jot down notes on a piece of paper. And then after work for 2 hours, while my family had dinner without me again, I was trying to recreate these scrawled things into notes that I could put into Epic. And it wasn't just me being bad at it, by the way. This was a system problem. All of us were doing this. And one of my colleagues sitting next to me said something very profound. She said, "Rushika, every day I lose a little piece of my soul. Every day I lose a little piece of my soul. People come to us with such big needs in primary care. And we have all this training and there are all these resources, but I just can't do it. And then the really damning thing is it seems to be getting worse and not better." And that's when I decided I could spend 30 years of my life beating my head against the proverbial, or not even proverbial, a real wall, or I could try to fix this. And that set upon a journey about trying to build new models of primary care. By the way, it's ironic to come here. So I started a little practice called Renaissance Health, rebirth of primary care. We're going to start from scratch, build something based on relationships and not transactions, actually try to improve people's health, not do more stuff to them. All that seems pretty obvious, by the way. And that led to sort of a 20, 25-year journey to do this at some scale. Ironically, this exact location, the Meridian Hotel, means a lot in that journey. So about a year into it, I had heard tell of a few other crazy people doing the same thing around the country. One of them, the sponsor here, Garrison Bliss, was doing this in Seattle. A guy named Tom Lee was trying to do it in San Francisco. A guy named Chuck Kylo was trying to do this with a little practice called Greenfield Health. A guy named Alan Dappin in DC. And I got a little grant from the Robert Wood Johnson Foundation saying, we ought to get us together. And we got together right here. They gave us a $50,000 grant. And I said, I don't know what will come of it, but I think it's important for this not to be sort of isolated people doing this, but we need to form a movement. And we need to get to know each other, and we need to learn from each other. And so we came here for about 3 days, courtesy of the Robert Wood Johnson Pioneer Portfolio. And I think that was a very early step in doing this. We eventually became called Direct Primary Care, but I'd love to see that the movement is finally maybe taking on. You, like lighting a fire, you light these matches and you see it smolder and smolder and smolder and smolder, and you hope eventually you have enough firewood, enough kindling that it actually sets ablaze, and hopefully we're beginning at that point. So it really is a pleasure to be here in this particular place. Thank you, Michael, for having me. So in the morning we talked about tools that communities could use to understand the primary care crisis and to begin building something better. And this afternoon I think the point is to talk about how do we scale what works, right? Well, we have gone beyond the point of having cute little pilots. We know what works. This is not a failure of knowledge anymore. This is a failure of execution and a failure of the system changing. And so we're going to talk about it. How do we learn from other systems? What does it mean to treat primary care as public infrastructure? And what can we all do action-oriented? What can we do when we go home? So we'll begin with our keynote speaker, Dr. Jonathan Fitzsimon, We'll share lessons from Ontario's work to expand access to primary care and what these lessons might mean to the US. Right? We are very US health-centric. You know, you've heard that we have the best healthcare system in the world. Those of us who work in it, I beg to differ a little bit on that. And there are plenty of things good about the system, by the way, and there are plenty of good people, and there's plenty of good intention. Our results, by the way, speak for themselves, right? And it is embarrassing what we do. I was just in Thailand. You know, they are a place which has significantly better outcomes than us at one quarter of the spend. And it's because they take primary care seriously. And because they think primary care isn't part of the healthcare system to feed the beast, they think it's actually part of the community. Michael called it this. So we're going to move in we'll move into a panel discussion on what it will take to make primary care a public good here, like they think in Thailand, like they think in Cuba and Costa Rica and many places, and I think probably to some extent, but probably as you'll hear, not completely in Canada. Then we move into table talks, where you'll hear directly from people organizing change in their communities and hopefully get down one level. So let's begin. We're going to hear from Dr. Jonathan Fitzsimon. He's a family physician, a researcher, medical lead of the Renfrew County Virtual Triage and Assessment teams in Ontario. Leads a hybrid primary care program that provides comprehensive team-based care for both in-person and virtual services to thousands of previously unattached residents in rural and historically underserved communities. Ironically, despite having universal health insurance, Canada has the same problem we have, that many people don't have primary care. Dr. Johnson is also an assistant professor of the Department of Family Medicine at the University of Ottawa and a clinical researcher at the Institut de Savoir Montfort, co-chair of Digital Enabler Committee of the Ottawa Valley Ontario Health Team, and recipient of the Ontario Medical Association's Glenn Sawyer Service Award. So his work offers powerful lessons how communities can use policy, technology, and care design to make primary care available to everyone. Please join me in welcoming Dr. Jonathan Fitzsimon.
And thank you all for giving me my first opportunity to visit Boston, which I'm delighted about. This time, last week, I was giving a presentation in Halifax, Nova Scotia, and I was reminded that in some parts of Canada, even in the month of May, you can still have below freezing temperatures. Well, someone in Boston got the memo, so thank you for turning the temperature this week. I appreciate that. For full disclosure, I do receive a salary for the clinical services where I'm a medical lead. That's funded by the Government of Ontario. I have a small clinical practice still, so I work as a fee-for-service physician in the community. I have some research grants from Inspire PHC, which is a primary care research organisation funded by the Government of Ontario. I have a small grant from the University of Ottawa and research support from the Institut de Savoir Montfort, which is a francophone research institute in Ottawa. Okay, enough of that. What am I going to talk about today? So I would really like, I put better understand, but the objective is perhaps even better understand, and with all due respect to Senator Freeland, I do want to talk a little bit about why primary care is so important. I feel like I had some new spins on that, which may be useful to you all here. I'm going to talk a little bit about what we've been doing in Ontario, and then I hope that at the end I'll be able to leave you some thoughts and ideas about how we can go about delivering primary care for all. By the way, I'm scheduled for an hour. I think that's a long time to listen to anyone go on, particularly me, so I will cut that short a little bit and maybe save 10 minutes for questions at the end. I don't have one of the tabletop sessions, so I will finish a bit early so there'll be time for questions at the end. Okay, so why? Why are we here? Why are we talking about this? Why is it so important? Let me ground you a little bit with the system in Canada. I'm sure I don't need to. I'm sure you all know that Canada is a federal country. It has 10 provinces, 3 territories. But just in case you don't, there you go. That's your little neighbour to the north. The largest province by population is Ontario, where I live and work. So 16 million of the 41 million Canadians live in Ontario. And one of the reasons I mention this is because although federally Canada has a Health Act, it's laid out in federal law what all Canadians are supposed to be entitled to in terms of healthcare, responsibility for delivering healthcare is a devolved responsibility, so it's the provinces that have the responsibility for delivering healthcare. I do also want to define a term that we use very commonly in Canada, but I understand it might not be as common here, attachment. So whether we're talking about rostering, enrollment, empanelment, we use the term attachments, which does even in itself have some slightly different definitions across Canada. But I'm going to use the definition that is enshrined in the Primary Care Act, which is a piece of government legislation in Ontario. Bill 13 came into law June last year. I'm going to come back to that. Let's not lose sight of the fact that I've just put up a legislative bill, the law of Ontario, as a Primary Care Act. And it defines attachment as a documented and ongoing relationship with a family doctor or primary care nurse practitioner or primary care team working in a publicly funded system. Okay, I'm going to take us back. 1971. Julian Tudor Hard, he was a British GP working in a rural community in South Wales. And he wrote a paper that was published in The Lancet entitled The Inverse Care Law. It became a landmark paper where he stated that the availability of good medical care tends to vary inversely with the need for it in the population served. We hear phrases like those that shout the loudest get what they want, but also those that shout the least, or perhaps least able to advocate for themselves, often the ones who need the care the most. And of course Barbara Starfield and her team and the mountain of evidence that she and colleagues produced about the importance of primary care, the famous Starfield 4 Cs, that first contact, comprehensive, continuous and coordinated primary care, particularly that relational continuity that we heard spoken about this morning. And yet in Canada, 18% of Canadians live in rural communities, but only around 8% of physicians practice in those communities. We heard a little bit earlier this morning about budgets and percentages of budget, but if you break it down as a percentage of total healthcare spend on primary care, Canada lags behind other wealthy nations. We spend about 5%, just over 5% of our total healthcare budget on primary care. The OECD average is around 8%. And some of the most high-performing systems, so in Scandinavia or in European countries, that total gets to closer to 10% and sometimes above 10% of their total healthcare spend. So 5% of Canada's healthcare budget on primary care, and yet 50% of touch points in the healthcare system every day are in primary care. So when you roll together hospitals, emergency departments, specialist visits, x-rays, lab tests, every other touch point with the healthcare system put together is still less than all of the touch points in primary care every day. So I've spent the last 2 years working on a program of research about the impact of primary care attachment, but also the duration of the time that people have both attachment, where they have that documented formal relationship with a primary care clinician, and the length of time that conversely they spend unattached without access to primary care. The international evidence is clear, building on the work of Starfield and colleagues, that primary care attachment improves patient outcomes, and the reverse is true, that when people do not have a regular primary care clinician, the association is with worse clinical outcomes. And when we looked and delved into the duration of that time, perhaps I should have mentioned just one thing earlier as well within Ontario. And I've realised listening to your speech just how important that context it is. The responsibility of health to deliver healthcare to the government in Ontario, which means essentially, and I'm oversimplifying just a touch, but essentially, the government in Ontario is the single payer system for healthcare in Ontario. And so that means that all physician billing goes to the Government of Ontario. All reporting of hospital touchpoints, everything from long-term care, nursing home, through to lab testing investigation gets reported to the government, and that data is stored centrally. And so there's an organisation called ICES which holds all those data sets. And so all the way back to 1986, researchers can have access to population level health data in Ontario. And so we were able to go back year by year and see for the whole population of Ontario, whether you're attached to a primary care clinician, or whether you are not attached to a primary care clinician, and then count back the years to see that duration of that state of attachment or unattachment. You know, I mentioned about those high-performing countries spending more money on primary care. It's interesting when you talk to colleagues in Scandinavia or in European countries, as I do, if they talk about continuity, you know, let's say a family doctor retires, what do we do with that panel of patients? Where do those patients go? Do we assign them to one of the other doctors in the clinic? Do we assign them to a nurse practitioner in the clinic? Is it a team approach where these people get their ongoing care now? Or do we have to reassign them to a different clinic? They have all of these conversations, but the idea that there'd be a period of time where they don't have primary care, that's an alien concept in Scandinavia and Europe. So when I put forward that, no, it's not just low and middle income countries where not everyone has access to primary care, but in Canada and the US, this is still a very real thing. They kind of look at me with a bit of surprise and wide eyes. And this scoping review where we looked at the duration of attachment and unattachment, of the 30-odd papers that we looked at in detail, only 2 were actually dealing with the duration of unattachment, and both of those were Canadian papers. So after the scoping review, we started to look at, in detail, to try and quantify the scale of the impact of not having primary care. So we were able to look at unattachment and break down by duration of unattachment and do adjustments for the whole population, where we could see very clearly the association with unattachment and increased healthcare utilisation, so typically emergency department visits and hospital admissions, and total healthcare spend. That's not surprising. But perhaps what was a really important additional point was just how much more pronounced those increases were when we look at people with multimorbidity. So multiple common chronic conditions, this phrase multimorbidity, often associated with polypharmacy, so 4 or 5 chronic diseases, 2 or 3 medications for each of them. These are the most clinically complex patients. And for that group, for that cohort, those increases in healthcare utilisation and total healthcare spend were the highest. And so we're looking at 2023 Canadian dollars there, but the ratio is the sort of point to take away. When you take that cohort of multimorbid patients, and you do all of the adjustments for age and sex and whether they live in rural or urban communities, their income quintile, and you're left with a attached versus unattached comparison, not having primary care when you have multimorbidity more than doubles your total healthcare cost. But I actually wanted to focus more on the final piece of this sort of program of research, which we published earlier this year. And this is the impact on mortality. So the association with mortality, you know, we can talk about the cost and, you know, maybe that sort of appeals to policymakers and politicians. We can talk about healthcare utilisation and that appeals to the leaders and organisers of hospital systems. But it probably doesn't get much more important to patients than talking about mortality. And we've heard a lot about how there could be resistance, whether it's from the insurance industry or whether it's from the health system industry. But actually getting the population voice, getting the voice of people so that they start to bring this to their elected officials is an incredibly powerful tool to start to initiate change. This paper made it to the front page of our national paper, Sure, I'm blowing my own trumpet a little bit there, but where else do we get primary care research on the front page of a national paper? Now, 3 Canadian skaters won gold medals the day before, so I didn't quite get to the headline, but in the silver medal podium position there, primary care research. And I make the point in all seriousness to say that it caught the imagination of the public. People find this important, so then the media think it's important, and then it gathers this momentum, and very, very quickly that gets to politicians. Because at some point there are elections, and at some point politicians have to come out of their offices, you may say ivory towers if you want to, and knock on doors and speak to people and ask for their vote. And if the response is constantly, why don't I have a doctor? Why doesn't my granny have a doctor? Why do my neighbours have care with a primary care clinician and I have to go and sit and wait in the emergency department for 8 hours when my kid's got an earache? That resonates with politicians. It's a really powerful motivator. And you're going to need powerful motivators to get beyond the influence of the large corporate lobbies of insurance and the healthcare system. So in that paper that we published earlier this year, we also, as I said earlier, we could go back year by year and see the status attached or unattached of the whole population. And so we separated people out into groups, ranging from the recently attached or unattached, meaning it happened in the last couple of years, all the way through to very long attachment, 15 years or more, including 15 years or more unattached without a regular primary care clinician. And the results were pretty depressing. Let's start with a slight positive. You can see from the top half of those charts, by the way, premature mortality is rated as dying before the age of 75. The top half of those charts are the groups that are attached. And the reference point is 15 years or long-term stable attachment. That's the vertical black dotted line on the left there. And you can see for those that are attached, it's almost a dose-dependent response there. You know, the longer you have stable attachment with a regular primary care clinician, the lower your association with mortality over the next 12 months. And then if you look at the bottom half of the charts, and you see that dramatic shift to the right, and you see in those first few boxes, that's the first few years of losing attachment, the shift to the right is the greatest. The shift to the right means that your association with mortality is higher, 85% higher. That's the same rate as getting a diagnosis of diabetes. So let's just think about that for a second. This is whole population data. There's no adjustments here. This is the whole package, everyone in Ontario. Having a primary care clinician, not having a primary care clinician, the association with mortality is the same as getting a diagnosis of diabetes.
Can I ask a question?
Sure.
How do you explain, though, for the people who are unattached for so long, that their adjusted odds ratio is lower than the people who are recently unattached?
Great question. Great question. So let me give you a scenario. You have multiple chronic conditions. You have a regular primary care provider. Your medications are reviewed. Your prescriptions are refilled. You have your diabetes review each year to make sure that all your things are checked. Your blood pressure is monitored. Adjustments are made when there's any concerns. And then your family doctor retires and there's no one to take over. So that period in those first few years is when it all explodes. When you've been unattached for a very long time, it's a bit of hypothesis in this, but we've also done some qualitative research which backs us up, and there's international qualitative research, that the longer people go without a regular primary care clinician is that they do start to find workarounds. They maybe are able to access community or other health supports. They can maybe start to navigate the system a little bit better for themselves. They understand when they really must go to the emergency department. Or perhaps they get connected to a specialist who picks up some of the slack of what a primary care clinician will be doing at a much higher cost. So there are workaround reasons as to why the longer people are unattached, and those impacts decrease. there's also an element of survivor bias.
Yeah,
You know,
exactly.
we can adjust and accommodate as best we can, but there's always going to be some residual confounding. And our assumption as a team was that there's a bit of survivor bias there.
Natural selection.
The unnatural selection, yeah.
By the way, I'm totally happy with that. Just stop me and shout out if anybody has a question. Unfortunately, it gets even worse. So when we segmented out by levels of chronic conditions, so we used the Johns Hopkins aggregated diagnostic groups to assign people either essentially no chronic conditions, then low, medium, high levels of chronic disease. And so you can see the blue squares in the vertical line there basically just straddle the dotted line. You don't have any health concerns. You're not using the healthcare system. There's very little variation as to, even whether you're attached or unattached, to certainly the length of it. Doesn't make a huge amount of difference in terms of your mortality. As soon as you start to introduce some chronic conditions, everything starts to shuffle to the right. And then we start to see a bit of a separation as well. So now in the green squares, you can see the top half, people who are unattached, sure they're to the right of the blue box, but in the bottom half of the charts, those green squares have shifted even further to the right. And the more chronic diseases you accumulate, the further that shift, and then look at that dramatic swing to the right for patients with multimorbidity. And again, the same scenario, those first few years of losing your primary care clinician, when you have multimorbidity and polypharmacy, you are in the highest risk group. Even just comparing the multimorbid patients again, like for like, double the association with mortality. But if you think of this through a policy lens, those patients with multimorbidity who have just lost their family doctor, they're 12 times more likely to die in the next 12 months than somebody who has no chronic conditions who we've just reattached to a primary care clinician. So of course the goal is for everyone to have primary care. Everyone benefits from primary care. We want to turn off the tap. We don't want these patients who are currently blue squares with no chronic conditions to just go on and develop diabetes and high blood pressure and other chronic conditions. But in terms of urgency, in terms of the most need now, it's these patients with multimorbidity who have lost access to regular primary care, who are at the most risk and have the biggest impact on our system. And dying early, premature mortality, even higher, 16 times the association when you look at it from that lens. Okay, so the lessons from the research that we finished in Ontario, when we look at that burden posed by unattachment, they reinforce the international evidence. We know that primary care attachment has dramatic impacts on both our healthcare system, our healthcare costs, and of course on key clinical outcomes like mortality. Perhaps what's new is how we've identified this really critical vulnerability window, those first 5 years, most markedly for patients with multimorbidity. And so I think it is an important sort of policy point to just think on, that alongside the long-term goal of achieving primary care for all, a little bit of extra thought around that particularly vulnerable group of patients with multimorbidity who have lost access to primary care. Maybe we need to think about also giving some prioritization to them. That's where we're going to get the most impact for clinical outcomes, healthcare costs, and healthcare utilization. Okay, I'm going to move on to the what. Essentially, I'll be happy I've moved on from the why now. So what have we been doing in Ontario to move towards primary care for all Ontarians? Well, I mentioned earlier Bill 13. So an Act of Parliament, passed through Parliament, now is the law in Ontario, that by 2029, we're not there yet, there's still work to be done, but by 2029, 100% of Ontarians will have primary care if they want it, as defined by attachment that I brought earlier in the presentation. 100%, not some, not most, not even just the patients with multimorbidity, everyone. It's in legislation, it's the law of Ontario that by 2029 this will happen, this must happen, and money has been allocated to make it happen. Across Canada, the commonly sort of quoted figures around 20% of Canadians do not have attachment to a regular primary care clinician. So Ontario has already started to fare better than the other provinces and territories across Canada. We're now sort of touching 90% attachment. 10% is still a lot of people. It's still over 1.5 million people that don't have primary care, so there's a lot of work to be done. But one of the key aspects of what Ontario did was, and credit where it's due, was a really smart move by the government of Ontario. So this is Dr. Jane Philpott. She's a family doctor by background. In 2015, she actually stood for elective office. She became a federal member of parliament and was immediately promoted to become the federal health minister in Justin Trudeau's first government. She had a couple of other cabinet positions, and then in 2019 she actually resigned from Justin Trudeau's government. Whole of the story, we can save that for over drinks later if you want to ask me about that. But she then went on to become the Dean of the Queen's Medical School in Kingston, Ontario. And then last year, Doug Ford, the Premier of Ontario, who leads a Conservative government, appointed Dr. Philpott to be the chair of the Primary Care Action Team. So we have a well-respected physician, family doctor background, respected across the political aisle, and well-known and well-liked by the public. She's written several books, she makes lots of media appearances talking about primary care. So a very credible, very respected champion for primary care, with now the responsibility assigned to her to deliver that mandate that the legislation has, so that all Ontarians will have access to attachment to primary care by 2021. I see a question at the back.
Connecting could be as simple as saying, okay, in a computer system, the closest person is, they're connected. So what's the working definition of having a connection, other than just on paper?
No, it's a great point, because again, you might say that politicians can be a bit weaselly with their words and make things to sort of sound like they want. But the language of the bill is very clear. So that definition of attachment that I said, just to sort of tell you this is the definition of attachment I'm using, that's the language in the bill. So connecting is some of the snappy media headlines in what goes out on the social media posts, but in the bill the language is attachment. So you are attached to a family doctor or a primary care nurse practitioner with a primary care team working in a publicly funded system. So the definition is very clear in the legislation. But they've also done other things. So, you know, how to go about doing that. It's all well and good to say here's some money, but they've created and expanded over 300 family health teams across the province. There are a list also included within the bill of established standards. And what's really interesting is that the list of standards that all Ontarians should expect from primary care is based on an 18-month project that was led by a family doctor researcher colleague of mine, who went all across Canada holding focus groups, asking for information from Canadians, what do they want from primary care. That was called the Our Care Project, if you wanted to look it up. At the end of it, there were 6 standards of the Our Care standards, and they're almost verbatim lifted into the legislation. So if ever anyone as a primary care researcher wanted some encouragement to see how their work could translate to policy and law, that would be the example, the Our Care study led by Dr. Tara Keelan. The government have set milestones where they will give regular public updates on how the action team is delivering. They've committed to modernise the centralised wait list. It's called Healthcare Connect in Ontario, where people who don't have a doctor can register on the list. And a whole list of other sort of points that they've committed to do, including to work towards a single primary care health record.
more about that?
I can, yeah. I think there are 17 different electronic medical records in Ontario, and none of them talk to each other, and none of them talk to the hospital systems. So maybe the 17 does include Epic and Cerner and the ones, but there are a lot of other record systems that do not talk to the hospital system. That's clearly a well-recognised problem. And so one of the commitments they've made, and again, this is where, okay, we've got a bit of political Weasley language, you know, to commence work towards, I think is the phrase. All right. I've given them credit, I'll give them a bit of a push on that one as well. That needs to be firmed up, but a single primary care system. Some of you may have picked up that my accent isn't quite as Canadian as others, that originally I'm from the UK. So where I went to medical school and trained in family medicine, it was a single primary care record. It was very straightforward, and there's been iterations of it, but it's still essentially a single primary care record across the whole of England and Wales, and so you can access 58 million patient records if you're a researcher in the UK.
So the objective is to get to a single source of truth, if you will, or information about each patient in a single record.
In a single record, accessible by the patient as well. That's one of the standards, is that patients should have access to their medical records.
And does that mean all providers, like dentists, eye doctors, etc.?
Well, therein lies the detail of that language. A primary care record, are we talking about primary care, or are we talking about primary health care as per the WHO definitions, which would include all of those other sort of public health and community sort of sources, or are we just talking about the primary care record? I don't know the answer to that. So let me summarise what Ontario has done. We quantified the problem. I think it's really important, after identifying that it's a problem. I think we well and truly are, you know, across both Canada and the US, beyond that point of recognising that there is a problem. But quantifying the problem is important. And we made a commitment to solve it. A political, legal, financial commitment to solve this problem has been made. And responsibility has been assigned to a very obvious and very visible champion for delivering this primary care reform. So I would love to tell you that I've just got one slide left, and I'm going to put a few bullet points to tell you exactly how we do it. But I've got about 15 or 20 minutes left, so I should probably not do that. I don't think you'd believe me anyway. It's complicated. There's a lot going on here. Yes, we need more medical schools. Yes, we need more family medicine resident physicians. We need more nurse practitioners. We need expanded teams of interdisciplinary health professionals in primary care. We need payment reform. And that's just to get everybody attached to a primary care clinician. Once we've got everybody attached, we need better primary care. As we heard this morning, attachment doesn't necessarily equal access. You can be attached to a family doctor, but if you're told that your next appointment is 8 weeks away, it's meaningless attachment. If you have to drive 2 hours, or if you have to drive 20 minutes and don't have a means of driving 20 minutes, the travel burden is overwhelming. So we need to think about access. We need to think about the barriers of travel burden. We need to think about language concordant care and culturally sensitive care. That's to get primary care working at its max. And even when we get that, we need to then think about, well, how else do we get communities and populations maximising their health and well-being and not having this millstone of chronic disease around their necks for the rest of their lives. So it can feel overwhelming. But I was told to always have a little bit of audience participation, so feel free to shout out your answer. How do you eat an elephant? One bite at a time, there we go. And just in case there's any vegetarians in the room that don't want to eat an elephant, you can take one step.
Thank you, John.
Okay, but I do want to leave you with one example of an approach that we've been using in Ontario that's been able to do something now. very real. So yes, all of the long list of things I just rattled through need to happen, but they take time. You can't solve an HR deficiency in primary care overnight. It takes time, and that healthcare worker pipeline needs to be put in place, but then it takes time for it to actually take effect. But one of the things we've been doing in Ontario right now and getting immediate effects is utilising something called a hybrid approach to primary care. And there are a few key elements that help describe what a hybrid approach is. So firstly, we leverage the underutilised capacity in the existing clinician workforce. Typically, when I say that we leverage the unused capacity in the family doctor workforce, people look at me like I've got two heads. But it's true. There is available capacity. When you start making the opportunity to work very part-time, to work family-friendly hours, to not work every month of the year, to still practice clinically without also having the commitments of being on the committees or the board, or to have to take ED shifts in your community hospital or be a hospitalist. When you give physicians and other clinicians the opportunity to work from home perhaps, that flexibility opens up capacity with the existing workforce. And in pockets where perhaps there is close to or even an oversupply of the physician workforce, then having a mechanism to distribute that capacity to those hard to serve communities where there's a deficiency in the workforce becomes really crucial. But we also leverage local resources as they're available, particularly local coordination, so people who understand the local community, who know what resources are available and perhaps what is not available, or do people have the most challenges with. You say understanding the community needs and the community resources is really crucial for that third element of a hybrid approach, where you blend the virtual care resources of clinicians working remotely with the in-person resources of people who live and work and are embedded in the local communities. I mean, when you're able to blend those services to this hybrid approach, we see an overall increase in the system capacity, which is available now. It's not waiting for a new medical school to be built or a new residency program to churn out more doctors. It is available now. And we've done it, we've used the hybrid approach in a number of ways. So the first way that we used it was for urgent care. So I actually work in Renfrew County. It's the largest geographic county in Ontario. Historically very underserved, very high rates of unattachment. A diverse population, of course, but it's typically older, sicker, poorer population than the provincial averages. And so when the pandemic hit, oh, by the way, no walk-in clinics or urgent care centres, so if you don't have primary care, you go to the ED or you don't get primary care, or you don't get care. So when the pandemic hit, and the last thing we wanted was people converging on the emergency departments, we said we really need to focus minds and come up with a way of providing urgent care. And so we used the hybrid approach. So we have a pool of physicians that work remotely. We have a pool of medical receptionists. They're all locally experienced receptionists, but they all work from home or remotely or in their clinic or wherever they want to be honest. And it's very simple on the surface. Patients call a single number, they speak to a receptionist, they're scheduled typically a same-day appointment with a family doctor, occasionally next morning, and they have their clinical assessment, usually by phone, sometimes by video. And what we also do is we tap into, again, flagging what's available locally. In Renfrew County, we have quite a robust community paramedicine program. So we're able to tap into the community paramedics and utilise their skills to provide some of the in-person examination and clinical assessment and point-of-care testing. We even have hybrid appointments where the paramedic will be with the patient in person, and then they'll bring in a family physician in real time by phone or video. And we have a small number of local family doctors and nurse practitioners who are also able to support their physician colleagues working remotely. Well over 200,000 family doctor appointments now have been delivered that way. Tens of thousands of patients have been helped. And in 2025 alone, we had over 40,000 family doctor appointments to the residents of Renfrew County. And interestingly, the vast majority, almost 70%, are to unattached residents. So there are still some, a minority, but 30% are to residents who are attached to a family doctor, but whether it's evenings, weekends, or it's just too long for them to have to wait for an appointment, and they can also sort of make use of this system, but predominantly unattached residents. And 70% of the people calling us say that without this hybrid approach to urgent care, they would have gone to an emergency department. And so we've been able to take out over 30,000 unnecessary emergency department visits in just one county in Ontario in 1 year. And interestingly, fewer than 3% of those calls, we obviously track all of our outcomes for each encounter, fewer than 3% is the physician advising the patient to call 911 or go to the emergency department. So the second way we use the hybrid approach is actually really to take it a step further, and that's to deliver attachment to a named family doctor, provide comprehensive team-based primary care, and those doctors, although they work remotely, are employed by and embedded within one of the local teams where there are also other doctors and nurse practitioners, just not enough to attach all of the residents of the community, but there are some available, and a publicly funded team of interdisciplinary health professionals, so everything from nurses to midwives to respiratory therapists and dietitians. And now more people can access those ancillary services as well as having a family doctor who they're attached to. Yes, they only ever get to meet their family doctor remotely. There's a whole spectrum that they can use it, from asynchronous secure messaging, telephone, video, or through to the examples you see there where they have a nurse in the room, the patient comes to the clinic and the doctor's on the video. They use digital stethoscopes and otoscopes and cameras and what have you to really maximise the potential of that visit. So they don't meet their family doctor in the room, and that's not ideal for everyone in all scenarios. But again, I would sort of just compare to the comparison of what else is there in Renfrew County. There's an emergency department. And so 7,000, almost 7,000 residents previously unattached, no access to primary care, emergency department or nothing as their only options, now have a named family doctor and access to a local clinic and a team of interdisciplinary health professionals. Tens of thousands of appointments, tons of preventative care work being done for these patients, really comprehensive primary care being delivered to previously unattached residents.
Can I go back? Let's go back on that
Sure.
slide. So you're saying 6,893 are attached to the hybrid teams, or you're saying that 6,893 were sent to our other primary care clinicians that were close to them and they were attached to other primary care clinicians?
So the 6893 are attached to a named family doctor who works remotely, but that doctor is employed by the local clinic even though they're never on site. But that clinic has the publicly funded team of interdisciplinary health professionals, and so the patients can have virtual care from their doctor. Their doctor says, no, I need one of my doctor colleagues or nurse practitioner colleagues to examine you. You go to the clinic, and that colleague will do the physical exam. You know, a bit like we have that teams of docs to do evening clinics to cover each other, that side of things. But also now all of those allied health professionals are also available to those patients because they're attached to a doctor.
Is that a product of the way you're compensating the doctors?
Yeah.
You have to do that kind of screwed up.
Yeah, exactly. No, it's a good point. This is quite bespoke. The IVC, the Integrated Virtual Care Program, where we do the hybrid approach to attachment, the moon and the stars aligned for us to be able to do this in this area because we had some salaried physician posts, which is unusual in Ontario, very unusual. They were unfilled. The money was going back to the Ministry of Health every year because we couldn't recruit people to physically relocate to those communities. But we could employ them whilst they were working remotely. So that was quite capped and limited. So it was quite bespoke. I wanted to put it up there just to show you the sort of scope and the potential of this hybrid approach. And we've done a lot of evaluation for it, so grounded in the quintuple aim framework, which is looking at patient experience, provider experience, clinical outcomes, healthcare costs, all through an equity lens. And we've done qualitative and quantitative analysis of both the urgent care version and the comprehensive attachment program with tremendous results. You know, patient satisfaction rates well into the 90%. So of course it's not 100%, that's what we strive for. It would be, I'd love to be able to say this is perfect for everyone, it's not, but it's very well accepted by those that are receiving it and by the clinicians delivering it. I want to finish on the final piece that we've been doing in terms of the how we can go about doing something now, particularly for these vulnerable, most vulnerable multi-morbid patients. It's still using the hybrid approach, but we call it supported attachment. And what we do, we leverage that same pool of family doctors working remotely. But as part of that $2.1 billion, Jane Philpott's Primary Care Action Team, part of that funding has been allocated to the 50 Ontario health teams to provide supported attachment, to ease the process. Yes, there are some more residents coming through the system now. There are some more nurse practitioners available. Some of the teams have expanded, so there's more capacity to attach more patients, but it's taking time. But what we want to avoid is for when that brand new resident comes in August or September, saying, here you go, here's, alongside your panel of 1,200 patients, here's 50 of the most complex multi-morbid patients that haven't had a doctor for 15 years and have a shopping list of issues that all need to be done immediately, and by the way, they all want to see you today. You know, that's burnout and overwhelming work just waiting to happen. And so supporting the attachment process is that we have this separate team that start off by doing an administrative onboarding, explaining the process to the patients, contacting them, talking to them, setting expectations, actually clarifying that during this period of 3 to 6, maybe 9 months, you're still unattached. We're not providing you with attachment to a primary care clinician just yet, but it's a process to that point. And understanding that our goal is to transition their care to a locally based primary care clinician for permanent attachment. The coordinator, the administrative coordinator, will build the chart, will enter all the details, will pull data sources, what's available, will gather records from the patient and information from the patient, and have things lined up and organised, ready for the clinicians to start the next phase, which is the clinical onboarding. And we start that with a pharmacist intake. Those of you that have worked in multidisciplinary primary care teams know that a pharmacist as part of your team can be absolute gold dust to a family doctor. You know, how many multi-morbid patients with their polypharmacy, they come in with a bag of medications, they come in with a shoebox. I swear I'm not lying, I had a patient come in with a suitcase of medications one time. To start your first encounter with just going through the medications is just, a heart-sink moment for a clinician. And so having an experienced primary care pharmacist say, sure, book me an hour with this patient and we'll go through them all one at a time. And so this pharmacist intake pulls data sources, so from the community pharmacy that's dispensing the medications to the patients, pulling any hospital records, speaking to the patients, speaking to their carers, finding out what they take over the counter as well as prescribed, and then documenting it on the electronic medical record in a way which is usable. It's not just free text, it's actually a usable sort of structure. So that time with the pharmacist is absolute gold dust. And then the family doctor comes in. So one of those urgent care VTAC doctors working remotely. Typically when people call the urgent care clinic, we might have 4 or 5 doctors working each day, and they just get assigned the next available doctor. But for these more complex multi-morbid patients in the supported attachment program, they have a single designated doctor. They have an extended appointment with this one doctor to go through those initial notes, to read through the note from the pharmacist and any advice or any sort of flags that they've raised, and spend some time with the patient, just identifying what are their problems. And sometimes that first encounter can literally just be documenting their problem list. and then starting to have a small amount of time to figure out, well, what are the priorities to you? What are the first things we want to get started on whilst we're waiting for a local family doctor or nurse practitioner to arrive? And we have bridging support available. We think the sweet spot is around 3 to 6 months. Realistically, in the early days of this program, I should probably say 3 to 12 months. We're still waiting for more doctors and nurse practitioners to come in locally. But bridging support meaning that when you do call the urgent care clinic, your child is flagged as being part of this program. All of the supported attachment doctors work at least 2 shifts per week on different days. So there's usually really good access to them, so you get to see your designated doctor virtually. And same thing, we tap into the local support. So we have a small number of family doctors working locally, nurse practitioners, the community paramedics, some of the family health teams have some of their allied health sort of capacity available to us as well. And so we tap into that local in-person clinical support alongside the virtual care provided by the designated doctor. So question in the back.
So it's striking you've got all the data on all these people already. They've got care plans they've been seen, you know the conditions, their medications, all their challenges. You can run that through, you can figure out what they need before they ever come to see the doctor. How does that data intelligence fit into that? That's what we're looking at.
So what you just described is what they're at after they finish with us. They're certainly not at that once they've started with us. That's our goal, to hand over what you just described to the new doctor as they come in. But when they start the program with us, bear in mind, many of these patients have not had a primary care doctor for 10 years. So when we go into their province-wide system, sure, there might be a handful of emergency department visits. There might be some lab results. There might be bits and pieces of work that's where our coordinator, that admin onboarding, can spend a bit of time and pull what is available there, but it's often woefully incomplete.
Have you used AI or thought about using AI to pull it together in a quick summary that may increase efficiency?
Yeah, absolutely. Look, the process we have now will not be the process we have in 2 years' time, I'm sure of it. We do have a patient-reported past medical history. I'm sure we will start to use some of the AI tools that assist patients in describing their own medical history and summarising. Yeah. Sure.
The EMR system, I agree with you, it needs to be a single EMR system for all primary care. But how does that work now with all this information coming from specialists, hospitals, ER, urgent care visits? In other words, they would all, I would think, need to be interoperable to get into what I would consider a comprehensive primary care record. Is that something?
Yeah, absolutely, Pete. That's exactly what we're doing. I'm kidding. That's exactly what we'd love to do. You're right. Of course, you're right. That, in an ideal world, that should be the norm. There should be this portal where anyone can sort of input. It can be sorted methodically and analysed in a way that makes the authorised users able to take out what they need and not have a mass of information that they don't need. That patients should also be able to look in, that their nominated carers should be able to sort of see the record as well. 100%, that's what we should have. I still think we're a very long way from having that. Certainly in Ontario. Yeah.
So, I'm Renee Critchlow, I'm a family doctor. I think I've heard you say family doctor more than anybody in Massachusetts in the history of the world. I just want to say thank you. I also want to say, does it actually say family doctor in the bill? Because that would be unheard of in this country. They would be like, no, and then you have to have peds, and then you have internal medicine, and then you have to have blah, blah, blah. But we have OB-GYNs who are saying they're primary care doctors.
Yeah.
How did you guys do that?
Yeah. Well, there's strong advocacy from the College of Family Physicians, very strong advocacy. That's a national College of Family Physicians, and then there's an Ontario chapter. And it's a very definite and deliberate choice to say family physician or family doctor. Yeah, I do have a bit of an issue with the phrase primary care provider. I'm a bit more comfortable with primary care clinician. But I'm a family doctor. I went to medical school, I trained as a physician, I specialised in family medicine, I see family medicine as a medical specialty. All through my career, I've worked with nurse practitioners, and I've worked with dietitians and respiratory therapists, and I have the utmost respect for them. And did I emphasize how important the pharmacist is? No, you know, I have huge value in the team of clinicians and the skills that they bring. We work really closely with paramedics. You know, I can't emphasize enough how helpful they are, how valuable they are to the team. I just don't see the need to say that we all have the same job title. I feel like a paramedic is not the same as a midwife, and to call them both primary care providers is to do them both a disservice. And I do feel that myself as a family doctor, that it's not describing my role adequately or appropriately if we just have this umbrella term to describe everyone who has a clinical role. Now I just got my 10-minute warning. I think I've got about 5 minutes, so if it's okay for the two of you, I'll just finish and then I'll come back to you first. If I may, I don't want to run out of time completely. The final piece is that transition. So we want to have a polished product, if you like, say, look, we've spent some time working with this patient, we've collated and documented their challenges and their problems, we've got it in a usable format for you. All of their meds have been reviewed, their medication prescriptions are up to date. Maybe we've done a couple of referrals to specialists that were really sort of necessary for them. And this is family doc handover, so, you know, here's a note, this is some of the things I've done, this is perhaps some of the things you want to pick up straight away for this patient. So a really smooth transition and handover to that local clinician who's going to provide permanent or longitudinal primary care attachment. So we leverage latent capacity. It's a real thing. It does exist. And we give that, distribute that sort of capacity to the patients that need it the most, and we do it now. And immediately take some of that burden away from the emergency departments and the inpatient units where these patients are getting some of their care. And it has that added advantage of a little bit of burnout protection for the new family docs and nurse practitioners who are coming into the local communities, who are going to start building their practice and providing longitudinal attachment to these patients. There's been things that have helped us, there have been challenges along the way. It's new, it's innovative, it's flexible, it's creative. I know that, you know, virtual care and digital tools doesn't appeal to everyone, not every clinician is happy and comfortable with that, but many are. It does appeal to many. There is a market out there for people that are really interested in and really wanting to join this sort of cutting edge of a new approach and a new system. And we're incredibly supportive. We bend over backwards to help the physicians settle in, to be flexible with scheduling, to give them the hours that they want, to support them when they're on vacation and not having to check their results. We provide coverage for that. So a very supportive environment for our staff. But there are barriers. I don't know if there's any middle-ranking Ministry of Health bureaucrats in the room, but if you speak to your average middle-ranking Ministry of Health bureaucrat and you use words like new, innovative, flexible and creative, they don't always give you a warm embrace. So we've had to work hard with our ministry colleagues.
The good news is we don't have any ministries.
But you still have bureaucrats. You still have bureaucrats, yeah. But even in the clinic itself, you know, people got new roles. We're asking colleagues to do an in-person examination for a colleague that works remotely. The non-clinical staff, you know, they're front desk receptionists. Interestingly, the reports we heard back from some of the receptionists was, look, prior to this, half my day was dealing with angry people. People say, oh, well, you're my local clinic. Why can't I come and see you? Why don't I get a doctor? My neighbours can come here. Why don't I have to go to the emergency department? And oftentimes these are receptionists who live in that community. It's their neighbours. It's their family and friends sometimes that they're talking to. So we said, okay, you know, we're going to give you a lot of work. We've just attached 7,000 patients. This is a lot of work for you. But what they tell us is, well, now my day, I'm calling people. You know, we've got capacity now. Do you still need a family doctor? So it's really transformed the quality of their professional day. So Starfield, Tudor Hart were right. Primary care, we know, delivers better cost outcomes. It gives better system outcomes. And from the data, particularly on mortality, we see the most important clinical outcomes, patient outcomes are improved. In Ontario, we recognised that we quantified the problem. We provided political, legal and financial commitment to solving the problem, and responsibility was assigned to a credible champion for primary care with resources for them to use to solve the problem. You can eat your elephant or take your small steps on a long journey, but be innovative, be flexible, be creative. You'll have noticed that as well as using family doctor a lot, I use the word approach all the time. I don't talk about models. We have to think about local flexibility and understanding the local context and make these sort of approaches bespoke and tailored to suit the communities where they're going to be delivered. Stay focused on that goal. Universal primary care is the goal. We still have work to do in Ontario. 2029 is still 3 years away. 1.5 million Ontarians still don't have primary care, but we're focused on achieving that. And I have absolutely no doubt, when I look around this room and I hear those talks this morning and I see the energy and feel the energy in the room and the passion that all of you have towards primary care, I've no doubt that you too are going to achieve that goal of primary care for all Americans. Thank you very much for hosting. Brian, have we got 2 minutes? Are we done?
We have 2 minutes.
2 minutes, yeah.
So, I had a question about the primary care attachment study. So, my interest in everything going on here particularly is in epidemiology and causal inference, and how the questions we ask in terms of how we define ill health and where that comes from are really important for how we intervene on it. But here, especially with figure 1 and the mortality graphs, it seems to me that it might run into an underdetermination problem. Specifically, like, how would we distinguish between unattachment actively harming the multimorbid patients versus the same multimorbid unattached patients just being part of a specific subgroup that would already have this elevated mortality regardless of their attachment status?
Well, I think the simple way, I'm going to keep it simple because we're short on time, but the simple way I'd answer that is to look at the fact that this is population level data.
Okay.
So even with those nuances, even with those variations, even with some of the elements we talked about earlier that, you know, maybe there's some survivor bias, of course there's still some compounding in the groups. But when you look at those magnitude, 12 times the associated risk of mortality, is it 11.5 or 12.5? I think you're probably right that there's some sort of argument on that. It doesn't matter, it's huge,
Yeah.
It's huge. And so for population level data, with orders of magnitude of this scale, I think it dwarfs those sort of nuances where there may be sort of statistical challenges with the data for sure. I don't have a tabletop, but I'm certainly around this afternoon. I'm really happy if anybody has any questions and you'd like to just come up and approach me. I'd enjoy answering your questions.